Muhammad Hisham Gouda, and sorry to interrupt you multiple times for the big hassle of this noise in the background. So it's my honor and pleasure to have you as a mate or buddy in this session to run the discussion. So I trust this is the last lecture of the second session. So if all panelists kindly either shared on this session or not, please unmute your mics and we'll start to go through the questions. And I trust one of the most valuable points of this is the discussion. So we have until 20 minutes more from now to run the discussions. We have good amount of time. So I will get the first question here, and it's from anonymous attendee, and he's asking, is the MRCP a must or mandatory part to enter into the intensive care training in United Kingdom or not? I trust we can, if you have an input, please go ahead. Anyone have an input? I'm not nominating or naming anyone to answer the question.
Thanks, Walid, for the question. So in terms of intensive care training, so intensive care training starts from ST3. So there's 3 routes you can enter to intensive care, either through medicine, which is doing MRCP. So yes, you need to have full MRCP to enter ST3 in ICU, or you can enter it from the anesthetics. So you need to have your primary FRCA, which is anesthetic exam, or from the A&E specialty, you need to have the full MCAM to be able to enter on the training, or equivalence, you can have the European Diploma of Intensive Care, which is considered a point of knowledge to enter into the ICU training. So this is from the exam point of view. So there are actually different routes to enter to the ICU training, depending on what's your background specialty.
Perfect. So 3 questions from Riham Gabr. Thanks for your extensive thoughts and share. The first question is, how can I record daily clinical practice? I would take the advice from Dr. Muhammad Gouda, how they mimic the trainees if they are doing a CCT.
First of all, try to speak to your colleagues, see what they are doing. And the problem with Caesar is that you go through the e-portfolio and you go through the paperwork. When you go through training, you go through the e-portfolio only. So if you go through any way, you need to have an e-portfolio in your training. So if you do ops and gynae, if you do surgery, if you do medicine, you'll have to have an e-portfolio open. To apply for an e-portfolio, you go to your Royal College, there is a certain fee that you have to pay, and then they open this e-portfolio for you. And then when you do your, let's say, surgery, when you see a patient, you can send something for Minitex, or if you discuss a patient with the registrar or senior registrar or the consultant, you can send the CBD or an OSAT if it's an operation. Now that's in the UK. In Egypt, it's a bit difficult, but what you can do, you can download papers from the Royal College as well. You fill it by hand and you get someone in your department who is who is Royal College recognized to sign it for you. Sorry for the interruption.
No problem. Okay, so I may offer an alternative pathway, Dr. Gouda. I did it myself. If you don't have the feasibility of e-portfolio, I submitted my Caesar application all via paperwork. I may advise you to join the Caesar Telegram group with 1,500 colleagues actively going on the Caesar pathway. You will find there a lot of documents that DOPS, KICS, ALMATS, multi-source feedback, a lot of documents, and I made sure that these documents are Word format. So you can edit them, you can add your hospital or your university logos to these papers, and then you don't have to go through the e-portfolio because you are not working in UK. I did most of my papers except the logbook by this way, and it was all accepted as long as your verifier says that this is a correct evidence. And luckily, I passed it from the first go, so there was no hassle with that one. I'll pass the mic to Dr. Ahmed Zaki if you want to comment on this one, because you're a Caesar Foundation here as well.
Thanks, Dr. Roy. Yeah, I agree. So there's different ways. Obviously, that's why I said if you are in the UK, things are a little bit easier because already working in the system, people around you will be aware of what does workplace assessment mean, MINICAC, CBD, all this kind of stuff. And if you are applying from outside the UK, then whatever you do there, you can go on the specialty college website as well, and they've got these forms already printed, so you can use the college websites, workplace-based assessment, the MINICACs and the CBD, or what you've done is a great job. What you have done, Dr. Walid, if you can print off this and add the logo of your institute or wherever you're working and get that signed. Other way of doing it is whatever every daily practice you're doing. So when you see a patient, you review the patient, you assess. This is all kind of documentation. So you can take a PDF copy of whatever you are doing daily with your patient in your practice, and that also counts as a daily kind of practice. You can provide that as an evidence of you are seeing these patients, and if you see patients in emergency department, it just depends on what kind of documentation you use in the hospital you're working in or your institute. But yeah, there's lots of ways you can provide that evidence.
Perfect. So instead of medical director, can I put section head? Can she change the title of her clinical lead or clinical director or medical director as per the name he is actually on in this institution? I would say definitely. I would like my input in this one. I may be wrong. They are asking you to use your titles in your job description. Don't use their titles. So if you are a specialist in your hospital, don't write a registrar. So you are a specialist. Specialist in UK means a consultant, while a specialist in our country means registrar. So they are recommending when you are presenting your evidence, don't use the British titles, use your country titles. But you have to explain what this title means. So saying the same, instead of medical director, you can put section head, but you explain this is the head of department, or this is the medical director of the hospital, whatever. So I think it makes a lot more sense to use the proper names in your institution rather than borrow different names. Otherwise, you'll be in trouble if your section head does not recognize this medical director, the new title you're giving to him. That's what I believe, if you agree with me.
Yeah, so, I totally agree. Yeah.
Okay. A question again from Rahab. What is reflective diary? I may give this question to Mr. Amr Salim. If you give us an input, what is reflective diary? Have you had done one before?
I think Ahmed will be better than me, Dr. Ahmed Zaki. A reflective diary, I'll leave it to you, Ahmed, to describe this. Reflective diary is basically a diary talking about you reflecting on everything that you've done. But Ahmed, I think...
Yeah, exactly, as Amr was saying. So reflective diary is just, for example, if you attend a conference or a meeting, so you reflect on that conference saying, what benefit did you get from this conference? Are you going, is this something that you would like to attend again? Are you going to change your practice based on what you have heard? Is this something or not? This is one example. Another example of if you are involved with, as I said, in any critical incident, any complaint, then you need to reflect on that. So what you have done, is there something that you could have done better to avoid this situation? What I can improve next time to avoid this happening? It's all part of the learning process, and it's a good, it's a way of showing a good medical practice, that you are always reflecting on what's happening throughout your journey to try and improve yourself and be and practice in a better way. Or it doesn't have to be necessarily a complaint or something bad, but as I said, whatever you do in your job, it's always a good way to be reflecting on your daily practice, the courses you have attended.
Yeah.
This is
perfect. So, Mr. Atif, do you want to comment on that, or do you have another comment?
I think that the word reflection might not be apparent for all people who work outside UK. What do you mean by reflection is that when you are in a situation, of course, seeing a patient, then after the situation that you think about it and analyze what did you do and how do you feel about it and how to deal with it better, or how did you learn from it. So the reflection is thinking about what happened and then think about how to do it better, or if there's something we did wrong, how to avoid it next time. Thank you.
Fantastic. Okay, so to the next question, do I have to have an FRCS? And I will ask surgeons to answer this question. European board is equivalent to the FRCS. International FRCS is equivalent. So we have 2 surgeons here or 3 surgeons here. I would get the input from Mr. Gouda or Mr. Atif or Mr. Amr. I don't know if Mr. Hussam as well can be in a position to open his camera and mic and tell us his experience in that. So we'll start with Mr. Gouda.
You're muted.
Muted, Ham.
Mr. Muhammad, you're muted.
Sorry, I think I'll leave this question to either Mr. Atif Al-Kholi or Mr. Osama Banna. They are the surgeons.
I can answer it actually. It depends what you mean, what you need it for what. You know, FRCS, okay, if you had FRCS, it will help you to get a better job, more experience, a higher job, like senior clinical fellow. But the question is not clear. If you have, the more qualification you have, the better chance to getting a job which suits you.
Okay, so in our profession in anesthesia, I may be requested to do the FRCA if I am sitting for the training. That is mandatory. Primary FRCA and final FRCA are mandatory to attend or submit an application for training. While in the past, when there was a Caesar CP, you're attending the training from the middle, it was still again mandatory. But to do the Caesar pathway, I can go with European Diploma of Anesthesia or European Diploma of Intensive Care or the Irish Fellowship of Anesthesia. So if you're doing the Caesar pathway, it's not mandatory to have the FRCA. You can get any equivalent. But if you are talking about, is it mandatory to be in the training in anesthesia? Yes, it is mandatory. Hopefully that's clear enough.
I want just for in surgical specialty, if you want to pass Caesar easy or quicker, you have to have the exit exam. So the exit exam, there's no FRCS now. There's MRCB, MRCS. It is the exit exam which is required. So if you have the exit exam, then you can go through either to Caesar and you pass quickly. If you go for equivalent like the European, it is very difficult. And again, it is the competency, is not the degree. But if you have the FRCS or the exit exam, this means first to go for the exit exam, the consultant has to sign that you are competent. So the competency part has passed. And then if you pass the exam, this means you have the knowledge as well. So for the surgical specialty, the exit exam is, I wouldn't say mandatory, but it will make life very easy for you.
Okay, yeah, go ahead.
Just let's put it in a simple words regarding the UK system. So the UK system is actually a tick box system, more or less. Most of the things over here, the visa, the CISA, everything is tick box exercise. So they put in their SSG, which stands for the specialty specific guidance, certain requirements. And if these are not met, I regret to say it would be very, very difficult, especially on highly competitive specialties, which are like orthopedics, not because they are the best, but because there are many of them. But something like maybe obs-gynae, anesthesia, A&E, they are struggling to fill in the post. So they will be a bit flexible, but not on the expense of the basics. So talking about surgical specialty specifically, CISA requirements, actually, they are telling you, you just need 6 months experience in that specialty and you can apply. But success is completely different story. So they say the only recognized exam, exit exam or qualification for CISA, say in orthopedics, because I'm orthopedics, is FRCS UK, not even the international FRCS. Anything else, they said they can look at, but they are mentioning also after that, it will be very difficult to prove the equivalency of these qualification, and our recommendation is to take the approved exit exam. So if I am in your place, I will not waste my time and waste my effort and waste my money in doing something that it will not tick the box automatically, because they are saying that when you apply for CISA, or you are even going for the exam when you are not in an approved training, actually you are unsuccessful until proved otherwise. So don't give them a chance to pick up anything, and try to always go, what I call, the term I like is positive bias. Always show them that you are over and beyond what they are expecting even from their trainees, if you can. Not less, because if there is anything less, there is no mercy. They will not be sympathetic in your situation. So in summary, for surgical specialties is a UK FRCS. You can try the others, but I think it will be a bit difficult. Not impossible, but almost impossible. That's my take about it. Thank you.
Thanks so much, Mr. Hassan.
Walid, can I just, sorry, is this question about Caesar, doing FRCS for Caesar, or is just FRCS for what? I didn't.
He or she didn't mention actually. That's why I highlighted the three differences.
Yeah. The only one thing I want to add to what Mr. Sam was saying is sometimes doing the exit exam is a little bit not on your side if you are trying to get into training. So if, for example, this person have done the FRCS and wants to go into training, he will be overqualified, and this might not be on his side. So it depends what he wants to do. Really, we need to know what he wants to do before just asking MRSP or FRCS. So it just depends what's his intentions. If he's going through Caesar, yes. If he wants to go through training, then I would say no.
Okay, so we'll bypass that point to the next question. Then the next question is for Mr. Gouda. I would really would like to thank you first. Your post on call. It's been a heavy day, and you're still with us. So really, thank you. How can you accelerate the years in CCT? I don't really understand what's meant by acceleration of years. I think she means that she wants to join instead of year 1 in training, year 3. So she finished in 4 years rather than in 7 years. Is that something doable, or how can that be done?
I think she wants to do what I did. So to enter, if you go as an ST1, you cannot accelerate. You'll have to go through the whole program, whether it's 7 years or every specialty is different. If you have a direct entry like what I did as an ST3, then you can accelerate maximum 2 years, which means you can jump maximum 1 or 2 years maximum. This is according to the deanery and according to the specialty. So for example, I entered Ops and Gynae training in the Northwest. I managed to accelerate 2 years, and I will answer the question now how I did that. But it's up to my deanery, up to the specialty, the head of school of this specialty, to agree for you to jump or accelerate these 2 years. Now, what I did to do this, to manage to accelerate these 2 years, as I mentioned in my lecture, I was already going through Caesar, not applied, but arranging all my stuff for it. So my e-portfolio was nearly done. All my competencies were done. All my exams were done. So if you remember, I mentioned to go to ST6, you have to be finishing your exit exam in Ops and Gynae. Again, every specialty is different. So when I entered as an ST3, I was already finishing all the stuff that ST6 and 7 do. And because of that, at my first ARCP, which is, as mentioned again, is like the appraisal, I sat with the panel, we looked at my e-portfolio, and all my evidence, I finished my exam, so I was qualified to accelerate the 2 years, as in my portfolio, I finished all the training required for an ST4 and an ST5, so I managed to go to ST6. I could have gone to ST7, but as I mentioned, the rule is maximum is 2 years. Now, this is your first ARCP is the only point that you can accelerate. So if you accelerate 1 year in this ARCP, then you cannot accelerate anymore afterwards. If you don't accelerate or you don't qualify for an acceleration, then you cannot do it the year after. I just want to mention something quickly about the previous question. As Dr. Zaki mentioned, sometimes if you finish your exit exam in different specialties, you don't qualify to go into training, or it sometimes make your chances very, very small. And in MTI as well, I'm not sure if Dr. Atif mentioned that or not, if you finish your exit exam, you don't qualify to go into MTI, I think so. That's in Ops and Gynae. I'm not sure about other specialties. Thanks.
Perfect. So the last question for this session to be answered live, and I may ask our speakers for the session to answer the rest of the question in writing, and to assure you all, this answered question, if they are not live, it will be available as well in the same page on the website as written answers. So please, our speakers, kindly few minutes after we finish, try to answer all the questions here, so we leave no questions unanswered behind. The last question to be answered live is from anonymous attendees. I believe Dr. Ahmed Zaki is the best to answer. How can I put my letters, like discharge letters or referral letters? Hospitals will allow me to take these documents. Is it possible to keep a copy of these documents with me? What do you think?
You don't need actually to have a hard copy. As I said, all the application is done electronically, so you can copy that as a PDF, and then you get it verified by whoever you choosing as a verifier from your institute. So, for example, if it's one of your consultants who is working with you, and then you will show him this document that you are using it as part of your evidence of training, and you're going to upload it on your application, so that's fine. So you don't actually physically need to take anything outside of the hospital. As I said, it's just all done electronically, so you can photocopy these documents as a PDF, and then you upload it on your website and get it verified. So
yeah, I trust, as long as the document you use does not indicate who is that patient, that you can do either in a hard copy format by erasing all the patient details, even if a nickname, remove all the patient details, or if you're submitting that one in a PDF format, you can do what they call redaction, or you can cut all the evidence, noting the MRN or the hospital number or the patient date of birth, patient name. All that should be anonymized with no sign about any patient. I trust if you ask your verifier to verify that, he can go back and discover who is that patient, but only you and him know who is that patient, so he knows that this evidence you are submitting via himself is authentic evidence. But apart from that, the medical council and the college, when they assess your papers for the Caesar, they don't actually need to know any patient details. They need the content and the reflection on the document you are submitting that proves you did this or that, but they don't need the patient details. So go ahead.
Yeah, no, that's exactly as I was saying. You need to, any document you're sending to the GMC, they need to be anonymized. They need to remove any patient identifiable details, name, date of birth, hospital number, any numbers related to the patient. So yeah, exactly as you're saying. Yeah.
Absolutely. Okay, so that takes us to the end of this second session, and we will meet you after 55 minutes, exactly at 15 past 2 or 2:15 by British time. And at this, we'll have 2 lectures and then a long session of discussion, 30 minutes discussion. We can again flag any questions left behind to answer that live. Then we'll go to the end of the day by 1 hour 15 minutes, and I urge you all to be there. We are doing a role model on job interview. I will be a guest or interviewee by Mr. Hussam Al-Banna. So he's going to give me a few questions that's coming from true interviews, and you will see how we answer that question. We can, if you are happy to do, get 5 or 6 volunteers from the attendees section, and they will be promoted to be panelists, so they can answer or sit in the hot seat trying to answer these questions. It's questions in the interview. We would really appreciate if you volunteer yourself. So after the last session and before that one, I'll ask who is volunteering for that. You can raise your hand. We'll promote you from the attendees section to the panelist section and share with us live. If you are volunteering to do that, please make sure you have a working mic and a working camera, and it is suitable. You are not on call or in the hospital to be able to do that. Saying that, we conclude this session and see you after a break. I wish you a good lunch. Thanks very much. See you after the break. Thanks very much.